Good morning, ladies and gentlemen. My name is Yoarina. I am the resident of Oral and Maxillofacial Surgery Department, Faculty of Dentistry, Universitas Padjadjaran, Bandung, Indonesia. The subject of my talk today is management and treatment considerations for patients with complex middle third maxillofacial and skull base fracture, a case report. First of all, traffic accidents have been representing an epidemic for current societies in related to morbidity and mortality by external causes. Maxillofacial trauma is a serious injury in the head region which is frequently found in the emergency department. The most common site of fracture were mandible followed by the maxillary and nasal bone. Severe injuries to the maxillofacial regions can complicate the early management because of its highly vascular zone are complicated by the presence of upper airway and proximity with the cranial cervical structures that may be concomitantly involved. The usual technique of airway breathing and circulations are often modified and supplemented with other methods in case of maxillofacial injuries. Fractures of the skull base are relatively uncommon. They have been reported to occur in 3.5 to 24% of head injury patients. Several clinical examinations findings highly predictive of skull base fractures include hemotympanum, cerebrospinal fluid, otore or rhinorrhea, petal signs, and raccoon eye. Skull base fractures are commonly associated with facial fractures, cervical spine injury, intracranial hemorrhage, cranial nerve injury, vascular injury, and meningitis. The purpose of this case report is to present the clinical and radiographic evaluation, primary management and treatment considerations for patients who suffered a maxillofacial trauma resulting in fractures of skull base, fractures of the mid-facial bones, and multiple lacerated wounds at facial and intraoral region. Here is the case presentations. A 26-year-old male patient came with wounds on his face about 11 hours prior to admissions. When the patient was riding a motorcycle with medium speed at Cianjur area, suddenly a motorcycle came from the opposite direction, hit him, caused him lost his balance, then fell down with mechanism. His face hit the asphalt first. There was no history of using helmet. There was history of unconsciousness about 15 minutes, nausea and vomiting. There was history of bleeding from mouth and nose. There was no history of bleeding from ear. The patient was under influence of alcohol. He was referred to Hasan Sadiqi Emergency Department for further treatment. Primary survey was normal with disability GCS 14. Secondary survey swelling and deformity at left wrist joint, swelling and excoriated wound at left foot dorsal aspect region. Here's the figure of secondary survey. Figure 2 is extraoral examinations showing asymmetrical face, edema and hematome at both of eyes, left cheek and upper and lower lip region, and subconjunctival bleeding at left eye region, punctured wound at left eyelid and lacerated wound at right cheek region, lower lip and chin region. And the picture below, figure 3, is the intraoral examinations showing lacerated wound at lower lip region, hematome at lower lip region, and the occlusion was intact. For adjunctive examinations, complete blood count examinations, cervical X-ray, thorax X-ray, skull X-ray, head CT scan, and 3D head CT scans. The next pictures was a head CT scan. It revealed bone discontinuity at mid-frontal regions, less than 1 tabula, hyperdense mass biconvex at left frontotemporal with volume 5 cc, fracture at anterior wall at the left maxillary sinus, hematosinus at bilateral maxillary sinus, bilateral ethmoid sinus, left sphenoid sinus, and left frontal sinus, also deviation of nasal septum to the left. The picture below was the 3D head CT scan of these patients. revealed bone discontinuity of frontal bone, lateral aspect of left orbital bone, nasal bone, bilateral zygomatic bone, and maxillary bone. So, we diagnosed these patients with mild head injury, epidural hematoma at left frontotemporal region, anterior skull base fracture, alcohol intoxication, closed linear fracture at frontal region, fracture at left distal and radius transverse displaced fragment classification type 1 Cerner grade 0, closed fracture at third shaft metatarsal transverse displaced Cerner grade 1, Lifford 2 fracture, fracture of Noe type 1, fracture of lateral aspect of left orbital rim, fracture of nasal bone, lacerated wound at right cheek lower lip and chin regions, lacerated wound of palpebrae superior of left eye, full thickness plus rupture margo palpebrae superior of left eye. This patient was under the treatment of neurosurgery department, ophthalmology department, orthopedic department, and oral and maxillofacial surgery department. The treatment from neurosurgery departments are observations of GCS and vital signs, head up 30 degree, complete blood count, PT-APTT, trauma series X-ray, IVFD, and ACL 0.9, injections of medicine, ceftriaxone, ketorolac, and ranitidine, and also conservative treatment. And from ophthalmology department, the treatment were primary suturing of left palpebrae, topical medical application on the left eye using chloramphenicol eye ointment, cold compress, and the treatment from orthopedic department were immobilizations with posterior slap foot distal and radius fracture and immobilization with boot slap foot fourth metatarsal fracture, and plan to perform ORIF elective under general anesthesia. In this slide, we can see the post-treatment pictures. The treatment from oral and maxillofacial surgery department were suturing of lacerated wounds extraoral and intraoral. Wound debridement was performed using sodium chloride mixed with gentamicin. Intraoral lacerated wound was sutured using silk. Muscle was sutured using polyglactin suture. Punctured and lacerated wound extraoral was sutured using nylon. Applications of head bandage using elastic bandage. Plan to perform ORIF elective under general anesthesia, minimum 14 days after the accident. Next will be the discussions. Maxillofacial injuries is a very common case in the emergency department. Trauma to the maxillofacial region can lead to airway obstructions, intracranial injuries, loss of vision, or long-term cosmetic and functional deficits. Even minor injuries can result in a significant casualty to the airway. These situations may be aggravated by diminished consciousness, alcohol, and/or drug intoxications, as well as altered laryngeal and pharyngeal reflexes, making the patients more vulnerable to the risks of aspirations. Endotracheal intubations is occasionally needed for the establishment of a patent and protected airway. Due to the physical examinations, look, listen, and feel, we assume that our patient has a clear airway. Although there was a discontinuity in his nasal bone, there was nothing problem in his mouth, so he can still breathe using his mouth, and his airway remained patent. The main life-threatening respiratory consequence of acute alcohol intoxications is respiratory depressions, decreased airway sensitivity to foreign bodies, decreased ciliary clearance, and aspirations. Gastrointestinal effects from alcohol intoxications include nausea and vomiting, also increase the risk of aspiration. In primary survey, we found that the respiratory rate for these patients was normal. There was symmetrical shape and movement of chest, and vesicular breath sounds indicate that this patient had no problem with breathing. And The reason we put collar neck for these patients is based on principle. In a complex maxillofacial trauma scenario, cervical spine fracture should always be considered, unless proven otherwise. The incidence is very less, ranges from 1% to 10% in all maxillofacial trauma. Generally, without the adjunct of radiographic survey, patients can be excluded from spine injury if they display the following. First, patients with normal GCS, not under the consequence of drugs or alcohols or others. And second, absence of pains or tenderness in posterior midline of cervical spine. And the third, devoid of distracting painful impairments. Maxillofacial injuries are very prone to massive hemorrhages, and life-threatening hemorrhage can vary from 1.4% to 11%. The source of arterial bleeding associated with midfacial trauma are internal maxillary, facial, and superficial temporal branches of the external carotid arteries and the ethmoid and ophthalmic branches of the internal carotid arteries. It is important to differentiate bleeding from the skull-base fractures and oral bleeds by careful observations of oral and pharynx for lacerations and tears along with the hollow test examinations. This method uses the principle of chromatography. The sign was consistently visible when CSF concentrations were 30 until 90% when mixed with blood. For these patients, we couldn't put any packing to his nostrils because the hollow test examinations was positive. It is an indication of anterior skull-base fractures. Putting in packing will increase the risk of meningeal infections and displacements of fracture fragment into the cranium. Nasogastric tubes and nasotracheal intubation should be avoided because the risk of inadvertent intracranial tube placement. This patient was given ceftriaxone injections 1 gram as the prophylactic antibiotics to prevent meningitis. Patients with skull-base fracture require admission for observations. Surgical management is necessary for cases complicated by intracranial bleeding requiring decompressions, vascular injury, or persistent cerebrospinal fluid leakage. CT scan examinations revealed bone discontinuity at mid-frontal region less than 1 tabula. Hyperdent must be convex at left frontotemporal with volume 5 cc suggests epidural hematome at frontotemporal region and anterior skull-base fracture. Surgical interventions is recommended in patients with 3 reasons. A. Acute epidural hematome. B. Hematome volume greater than 30 mm regardless of GCS. And C. GCS less than 9 with pupillary abnormality like anisocoria. In patients with acute and symptomatic epidural hematomes, the treatment is craniotomy and hematoma evacuations. For our patients, there was no indication for neurosurgical interventions, so the treatment was conservative. Most maxillary fractures are managed conservatively with soft diet and analgesias. Patients with mobile maxillary fractures require admissions and timely surgical review. The application of head bandage for these patients was intended to maintain the state of immobilizations. Minimal conducted motions is acceptable, but excessive mobility may induce poor healing. The nose must be examined for septal hematome, which can cause ischemic necrosis of the septal cartilage, perforations, and saddle nose deformity. The presence of increased intercanthal distance or telecanthus indicates disruptions of the ligamentous attachment or displacement of the underlying lacrimal bones. In every injury involving the orbit, an ophthalmologist should be consulted early, especially if lacrimal apparatus injury is suspected. Our patient was diagnosed with Noe fracture with lacerated wound of palpebral superior of the left eye full thickness and rupture margo of palpebral superior of the left eye. Immediate suturing on this region was performed to avoid further complication. on his left eye. I would like to end these presentations by emphasizing the main points. First, every physician in the emergency department should be able to recognize, diagnose, and perform basic management of maxillofacial trauma. Second, each case is unique. Severe injuries to the maxillofacial regions can complicate the early management. And third, failure to diagnose, manage, and refer appropriately can lead to loss of functions and development of secondary deformities that may be difficult to correct later with frequently disappointing results. Well, I've covered the point that I needed to present today, and I will be very interested to hear your comments. Thank you for your attentions, and hopefully we will see each other again soon. Thank you so much.